Hi, good morning, everyone. So welcome to our Unit 6 discussion. So today we're going to be talking about anesthesia care basics and death and dying in the OR. Okay, so let's get started. You guys are trucking right along here. We only actually have really two more weeks of discussion left. And then your last week, your Unit 8, Week 8, is more of a wrap up. So we're going to push right through to the end. So hang in there, okay? So our objectives here, today we're going to be talking about, what does anesthesia do? How do they take care of the patient? How do we take care of the patient under anesthesia? What's our role during the anesthesia process as well? We're also going to be talking about, surgical conscience, as always. We talked a little bit about this Maslow's hierarchy of needs last week as it relates to the surgical patient. Um, and this last one's a big one, demonstrating an understanding of death and dying of a patient as it relates to your job as a surg tech in the surgical environment. So here are your assignments for this week, Unit 6. A couple big points here, so make sure you get those in on time and that you're doing those fully checking the exact things that you need to be doing, the rubrics, etc. So get your first discussion post in by this Wednesday, and then your make sure you get two responses to your peers for full credit, okay? Some of you are still missing those. Again, go back and look at previous weeks to see if I have made any comments that you might need to adjust. If I took points off, I've made comments, okay? So go see what those were and make those adjustments moving forward so you don't make that same mistake again, okay? All right, so death and dying in the OR we're going to start with this topic, even though it's not a favorite topic, it's an uncomfortable topic, but how do we handle the loss of one of our patients? If you work in this field long enough, it's pretty much inevitable that at some point you're probably going to lose a patient, although it is not common. Of course, it also depends on the type of surgeries you're doing. If you're doing, critical care, open hearts, you may see that more often than other specialties or fields. But regardless, the loss of one of your patients can be devastating. Everyone will respond differently. Everyone has their grief process that they go through. Really, it's important to remember your own self-care, making sure you take care of yourself and not bottling it up. But something that someone told me once is, it's important to remember why we're doing the job that we're doing in the first place, and that job is the patient. So while, this particular patient may not have lived despite, every effort we may have made, it's important to remember that you still have another patient. The next patient deserves your undivided care, attention, focus. So in the moment, it might be hard to, you know, prioritize that, but that next patient still needs you. I have lost patients before. It is not an experience I wish on anybody for sure, especially when they're kids. That was especially hard. But we work together as a team. So the whole OR is very close knit. And you can rely on each other. If you work long enough and close enough together, you can get through it together because you're not going through it alone. Okay. So we'll talk a little bit more about that here in a little bit. So a couple key terms referring to death and dying that you need to be aware of. DNR, you've probably heard this term thrown around a little bit. Do not resuscitate is what that means. So as a patient, they have the right to decide their care when they come into that facility. Some of them are planned out. They know exactly what they do and don't want. One of them might be this DNR order. They don't want resuscitated if it comes down to that end of life care. Okay. And it's up to us to respect those wishes, even though we may disagree with some of these, even these others. We don't agree with what that patient decides they want for their end of life care. It doesn't necessarily matter. Okay. So we have to respect their wishes, their culture, their ethical beliefs on how they want to die. Okay. It can be a little difficult to wrap our heads around that sometimes. So the Advanced Care Healthcare Directive is an actual written legal document that states the individual's specific wishes regarding what they want to have happen. So it's very specific. You know, maybe they say they don't want any life-sustaining measures. Maybe they don't want to be put on life support, but it's okay to do palliative treatment. So, you know, it might specifically say what can and cannot be done. A living will is also a legal document signed by the patient. So you have that ability to make a living will prior to going into the hospital as well. But once you are hospitalized, you can have a legal representative from the hospital come in and have this done for you. So it's also stating what types of limitations or types of assistance that patient may want if they're near death or if there is a prognosis of death. So advanced care might be a little more specific regarding like types of palliative treatment or other things that they could have. And living will is a little bit more specific to the end of death, near death type of care. And this other one here, Elizabeth Kubler-Ross, maybe you have heard of this person before. She's a psychiatrist. I think it was back in the 40s, maybe 1940s. Been a long time, but she's one who proposed a theory that's there are stages of the dying experience. And here's the next cycle here. So it's something that most people will go through at some point, whether you are the individual faced with maybe a prognosis of death or somebody in your family, or even the death of the patient that you are dealing with as a healthcare professional. So this is just showing you that there are stages of grief when it comes to the end of life. It doesn't necessarily mean that you are going to go through every single one in this particular order. It also does not mean that you can't go back down. Let's say you just heard that somebody you love was diagnosed with something, cancer, maybe you jump straight to depression, and then maybe the next week you go to anger, and a couple weeks later, maybe you accept it. So it is not necessarily concurrent, and it doesn't mean that once you reach a certain stage, you can't go back. So it is fluid and it does change over time, and not everybody will go through every single stage. Some people jump straight to acceptance. It's just how they deal with it. So it's not necessarily right or wrong to be in denial and then go to depression. Okay. So just to familiarize yourself, these are the things that people can go through during the grief cycle. Okay. So some ethical considerations in death and dying. So as the surg tech, like I said before, we have to respect the patient's wishes. And this includes their right for self-determination. So everyone, the patients have the right to make decisions on how they live, how he or she lives, and dies. So, we can choose what we want to do to sustain life and what we want to do to end that. So that includes the Advanced Care Health Directive, that care planning. That also includes the types of palliative measures to be performed or even withheld. So this term palliative means types of treatment that will make the patient comfortable, but doesn't necessarily cure a disease. So it could be pain meds, it could be going home on hospice. There's a lot of things that fall under palliative treatment that aren't going to cure the patient, but make them comfortable. Okay. So that is part of self-determination. And then the right to die is basically stating that patients can refuse treatment. Whether or not we agree with their refusal doesn't matter. So if we think, man, this patient should still fight, they have a lot to live for, or, it's not that bad, they could probably make it through this. You don't know their whole story. You don't know whether or not, what other treatments they may have had, how they're feeling. So the patients can refuse that treatment, but we as healthcare workers cannot refuse to treat them. Okay, that's important to remember. We do have to respect patients' wishes, regardless of our own personal, ethical, or religious beliefs. We may not necessarily agree with how a patient chooses to die, whether or not they just refuse treatment. It doesn't matter. If we would have done something differently, that's up to them. So how do we as healthcare workers deal with death in the OR? So it's important to understand healthy coping skills. There's a lot of ways to go about that, and there is definitely a difference between healthy and unhealthy coping skills. I don't think it's any surprise that healthcare workers are at a higher risk of a lot of issues, okay? So we have to develop those healthy coping skills. What does that look like? Okay, one of them is something called a debriefing period. So let's say you do lose a patient in the OR. Um, this has happened to me on multiple occasions where, we lost a patient and we're kind of at a loss in the moment, like what happened, what could we have done differently? But the hospital or your facility should have some sort of organized support group for the OR team or for really any healthcare worker to go and talk about what happened. Kind of goes down to this one as well, medical discussion. So it's important to discuss, what we did in the case, what could have been done differently, if anything. Maybe there was nothing that could have been done, and it's important to understand that we cannot control everything that happens. Okay, so when patients come into the OR, I'll give you an example. We were doing a port placement for like putting in cancer meds for a patient. They, other than, needing cancer meds, they were actually pretty healthy. They just needed that easy access to the vascular system for that medicine. Got on the table, and as soon as anesthesia was administered, they coded. So it was unexpected. Anesthesia had cleared that patient for the case. There was really no other pre-existing conditions other than the cancer, but that patient coded, and that patient did have a DNR. So we couldn't really do anything legally. They didn't want any life-saving measures. So it was pretty difficult to sit there and watch that patient just die on the table when I knew that we could probably have saved that patient with CPR or other life-sustaining measures. But again, it's not up to us. That's what that patient wanted. And it was difficult to watch, but I had my OR family there to fall back on. And we discussed that. We discussed we can't control everything. Things happen for a reason. I have to believe that. Expression of feelings, healthy expressions of feelings. It's important not to bottle it up, which kind of goes into this one here. Speaking to a confidant, find somebody that you can trust to talk to, or just talk and have them listen. They don't have to talk back. So it doesn't have to be somebody in the healthcare field. It can be, a very close friend. It could be your psychologist, psychiatrist, whatever it is, no judgment. It's important to be able to work through those feelings and not bottle it up, because the more you start to bottle it up, the harder it is to deal with it. Self-reflect, you have to realize that it's not your fault, that everything happens for a reason, and it's important to find a work-life balance. If it becomes too much for you, and maybe you've had a lot of bad days in a row, maybe you've had several deaths of patients lately, and it's too much for you to handle, it's important to take that step back. So don't feel like you're letting anybody down, but you have to take that step back for yourself. That way, maybe you can regroup, get a good state of mind and come back and be a better help for the next patient. So here are some anesthesia terms. We're going to kind of transition here a little bit, but anesthesia key terms here. There are a lot of things that go into anesthesia. While we are not the person that is putting that patient to sleep, obviously, we still have to basically know everybody's job. It's important to know what everybody's doing so we can be a good team. So that includes knowing the basics of anesthesia. So let's just start with this one. What is anesthesia in the first place? The term literally means without sensation. If you break it down as a med term, AN means without, anesthesia is sensation. So when we're talking about anesthesia, we're not necessarily referring to putting the patient to sleep. That isn't what that term technically means, although that does occur usually. So without sensation can be accomplished in a couple ways. And I listed these here at the bottom: general anesthesia, MAC, and topical. Okay, so let's jump back up here. Analgesia is referring to without pain. So again, AN, this gesia is talking about pain. So we want our patients to not experience pain, whether they come in through a trauma case and are already experiencing pain, or when we make those incisions, etc. We don't want them to be in pain. So we're going to prevent that by giving them specific drugs, whether it comes from, the anesthesiologist or from us on the back field that we pass to the surgeon. So amnesia is another term you're going to hear pretty often talking about anesthesia, the inability to recall events and sensations. So this can be one of two things, amnesia. It can be either considered retrograde amnesia or anterograde amnesia. So if you, let's just say, for example, you fell and hit your head and maybe you suffered a traumatic brain injury and you couldn't remember anything from the time you hit your head and before, like years before it even happened. Those memories are gone. That is retrograde amnesia. Retro means backward. Anterograde amnesia is not recalling anything, let's say from the time that they are given, let's say, a sedative. A patient is given a sedative in, let's say, the holding area and throughout the whole case. They don't remember that. So a lot of patients will think that they were anesthetized, put to sleep in the holding area, or maybe, in their room, whatever it was, from the time they were given that drug and forward, they will not remember. So they may be coming into the OR and talking to you, carrying on a conversation, but they're not going to remember it most often if they've been given that amnestic drug. Another type of drug we'll give them is an anxiolytic. It's something to reduce anxiety. So naturally, most of our patients will be nervous, right? It's understandable that they're coming into a world that they have never really been a part of, probably. They don't know what's going to happen to them under anesthesia. They don't know, the outcome of the procedure. There are a lot of worries that go, into a surgical patient. Many of you have probably been a surgical patient and understand that anxiety, okay? So a Bair block is a type of anesthesia we can give to a patient that is called a regional anesthesia. So an anesthetic agent, a numbing agent, is going to be injected into a vein that blocks an extremity. So typically they're going to do a Bair block, usually on an arm, because if they're going to need to numb a leg or something in a lower extremity, they'll probably do it as a different type of regional anesthesia, like a spinal or an epidural anesthesia, which would numb from that injection site on the spine and down. Okay, so a Bair block is probably more common in an arm. If you're going to work maybe on a wrist for a carpal tunnel, that's a pretty good option. It's really not good for trauma, but it's good for those types of hand procedures, wrist, elbow. So laryngospasm is definitely of importance to us as surg techs. I'll talk a little bit about that here in a few, but it's a muscular spasm of the larynx, which is the voice box, which, if that muscle spasms, it's going to shut off that voice box, those vocal cords, and no air will pass through. So that's definitely could be considered a medical emergency. The airway would be blocked. So then 3 other types of anesthesia. So if you include regional, there's like 4-ish types of general anesthesia, I should say. General anesthesia is typically what we refer to as the patient being like completely under. So it's anesthesia associated with a loss of consciousness. So they're out of it. They've been given drugs to put them completely to sleep. These patients are going to need some assistance with breathing, like an ET tube or an LMA that would help with their airway. MAC stands for monitored anesthesia care. So this is not as deep of an anesthesia as general. So these patients may be slightly awake. Maybe you've heard that term, twilight anesthesia. That's a common, term. So they're kind of awake. They're breathing on their own. They could be out of it. They may not remember it. So certain cases can be done under a MAC. A lot will go into choosing what type of anesthesia they use for the patient. It will depend on the surgery being performed. If it's a 12-hour surgery, that patient's probably not going to be able to lay there conscious for 12 hours. So a general would probably be a better choice. If the patient is, let's say, a child and doesn't understand that they have to lay still or is not mentally capable of laying still for any amount of time, they'll probably have to do a general. Now, if the patient is, let's say, older and has pre-existing heart conditions that might put them at risk under general, we, in some cases, might be able to manage it under a MAC. You would just use a MAC, probably in conjunction with this last one, this topical anesthesia. So topical means we're just going to numb, usually with an injection, a sub-Q injection, could be with a cream, but topical anesthesia is numbing the superficial nerves of the skin or mucous membranes. But notice it says motor function remains. So if I'm going to take, like, we're going to be taking off a mole, let's say on the hand, we're going to numb all around where we're going to cut. It's going to numb those very tips of the nerves on the skin, but they'll still be able to move their hand, etc. They could even feel pressure. That's kind of one of the main differences between topical and this regional up here. With regional, it not only numbs that area, but it blocks the motor function. So if they did the veer block up here in the upper arm, it would numb the entire arm and render it motionless. They wouldn't be able to move, which is also needed sometimes for certain types of procedures. All right, so anesthesia goals. What are the main goals of anesthesia? What are we trying to accomplish with the patient going under anesthesia? These four things, and we kind of talked about what some of those terms meant. We want the patient to remain unconscious. We're assuming this is basically general anesthesia here. We want them to be pain-free, immobile, and we want them to have amnesia or have that amnestic effect. We don't want them to recall anything. You've probably heard those horror stories of, patients waking up in the middle of the procedure and can hear everything. They can feel things. We do not want that, right? Some patients are more at risk for that type of awake under anesthesia awareness type thing. But anesthesiologists have a hard job, I think. I do not envy them. That is not something I think I could do. It's basically an art form. I've heard them say this a lot. Anesthesia is an art because they have so many things they have to consider to find the right balance of drugs for each individual patient. It's not always one size fits all. Yes, they obviously have guidelines, but to find the right balance for that patient, for that procedure, can be difficult. So a couple terms I also want to talk to you about with anesthesia. This first one is called the phases of anesthesia. Notice this term phases, because the next slide I'm going to go to is talking about the stages of anesthesia, and they are different. I know it's confusing. So think of a phase, like if you're going through a phase in life, you're passing from one thing to another. You are going through a phase, you're going to go into something different next. Kind of the same concept here. There are phases of anesthesia in which the patient will go through. That is pre-induction, induction, maintenance, emergence, and recovery. So it's basically, before procedure starts, before they are anesthetized, and until they wake up and are recovering are the phases of anesthesia. So it's important to know the phases in the correct order, as well as what is happening in each phase. A lot of times they'll even indicate what the start of the phase and what the end of the phase is. Okay, so pre-induction, you're starting to give them meds, and then it ends when they start this induction phase, like they're going to be pushing in the drugs that would put them to sleep. So in pre-induction, they're also going to be giving them things like oxygen. We're going to be positioning that patient on the bed. A lot of things happen there. Induction is when they're starting to give those anesthetic drugs that will make them unconscious. Usually this phase, induction, will end when the airway is secure, whether that's through an LMA or an ET tube. Okay, then maintenance is when we will actually do surgery. Sometimes that's a certification question. They like to ask that. In which phase of anesthesia does the surgery take place? And it is the maintenance phase, okay? So this patient has been put at an adequate depth of anesthesia. They've had their sedative drug. something for pain, something for relaxation, muscles completely relaxed so we can do surgery. So drugs will have to be given to the patient throughout the entire maintenance phase to keep that maintenance phase, depending on, how long that case lasts. And then emergence is going to be at the end of the surgery. So as soon as surgery is complete, that last stitch is in, the anesthesiologist will then start to wake up the patient. They're going to end any of those maintenance drugs. They may even have to reverse them if sometimes maybe the surgery ends faster than they anticipated. We may have to reverse some of those drugs. Some drugs don't have a reversal, so sometimes you have to wait a little bit for the patient to wake up. Also in this phase, typically extubation will take place. That means they're going to remove that breathing tube, that ET tube, and allow the patient to breathe on their own. Okay. Now, if for some reason that patient cannot be extubated, it still kind of goes through the emergence phase, but they're going to be just sent to the next phase, which is recovery. So this is going to be when the patient will go to PACU, or maybe sometimes they'll go directly to the floor, like a critical care ICU, and then healing will begin. Right, so those were phases. Look at this one. It is stages of anesthesia, and they are different. Okay, so the way I remember the difference in the two, so you go through different phases in life, it's fine, you end up on the other side, right? Stages, let's say for example, you're going, through the stages and you fall off a stage. You fall off a stage and you might die. Okay, I know that sounds dumb, but that's how I remember the difference. If you fall off a stage, you look at this last one here, stage 4, respiratory and vasomotor control ceases. That means you are not breathing on your own and you will die. Okay, so that is how I remember the difference between a phase and a stage. So stage 1 of anesthesia starts with analgesia, which is that pain management, removing the pain. Stage 2 is the excitement stage. So this means, as we're putting that patient to sleep, there's, giving them those drugs to make them lose consciousness, muscle relaxation. One of the last sensations that a patient loses is their sense of hearing, okay? For whatever reason, I don't know why. So if you disturb the patient with like loud noises during this excitement phase, it can be very dangerous because they have that heightened sense, and it can cause an automatic nervous response that could cause that laryngospasm. We talked about what that meant earlier. So if the airway hasn't been secured and they are in this excitement phase and they've been, startled, that larynx could close shut and they're not going to get any airway. And it becomes very difficult to put in an ET tube when the larynx is completely shut. So and we're going to talk about this again in a minute, but be very careful during this particular stage. So anytime the patient is laying on the bed, getting ready to be put to sleep, you need to be aware of that and very quiet. Okay, we don't want any laryngospasms to happen. So then stage 3 is surgical anesthesia. Essentially, it matches up with the maintenance phase that we had previously talked about. These are just some things that happen during that particular time. We do not want the patient to go to stage 4. If you go too far, that is the overdose phase, okay? Overdose can lead to death. So again, anesthesia is like an art. So how does this relate to us? Anesthesia considerations for the surg tech. The type of anesthesia that is chosen for that particular patient does change sometimes what we can and can't do as surg techs, what types of things we may need, how we need to prepare the patient, whether it's positioning, things like that, or even what we can and can't say. Okay, if this patient comes in and they're just a local, they're just going to be having that mole numbed on their hand and fully awake and talking to you, you need to be aware of that. Okay, sometimes we're just so used to our patients being completely asleep and just kind of chatting about our day or whatever. You have to be very careful with what you say and how you act when the patient is awake. you should really always be careful with how you are acting and what you say in the OR. Anyway, you want to be professional, but especially if the patient is awake, okay? You are able to assist anesthesia whenever possible. I obviously understand if you're on the back table setting up the case, you have your job to do as well. But if you are free and at that particular moment not setting up your back table or sterile, you need to be with anesthesia. Okay, I see so many surge techs just sitting on a chair in the corner when anesthesia's up there, like needing a separate set of hands. You are capable of, just holding something for anesthesia while they get something. We obviously cannot, push meds or anything like that, but sometimes they just need an extra set of hands to hold something. That makes their job that much easier and they can focus on the patient. Okay. And if something does go wrong with anesthesia, you're right there to maybe even start CPR. Okay. You need to be right there and available. Again, you need to be quiet during induction and extubation because both of those phases is the excitement phase. As they're being put to sleep, that excitement phase with the heightened sense of hearing and extubation. It is both. So if you're banging your instruments around on the back table or you have the music blaring, you can actually cause a laryngospasm in that patient. A lot of actually anesthesiologists will yell at you. I've been yelled at because I wasn't paying attention, banging my instruments around on the back table, and it could seriously hurt the patient if you're not careful. Okay, again, be aware of the patient's level of consciousness, like I said before, with being careful with what you say. Be prepared for emergency situations at all times. So you have to be trained in CPR, basic life support, being aware of the potential dangers that could happen. We're going to talk about one here in a minute. CPR, obviously, heart attack, cardiac arrest, anaphylaxis. There's a lot of emergency situations that can come up with the patient that you need to be aware of. And you also need to have knowledge of drugs used on the field. A lot of books do go into the drugs that anesthesia will use. I think in a way it's a little bit of overkill for us as surge techs to know what anesthesia uses because we don't practice that. I would suggest that you focus heavily on drugs that you're going to use on your back table for numbing, like your lidocaine, sensorcaine, bupivacaine. You need to focus on maybe some cardiovascular drugs you'll have on your back table, like heparin, things that can be used for coagulation. Those things you're going to have hands on, okay? And if you have your hands on it, you are responsible for it because it passes through your hands to go to the surgeon. If something gets mislabeled or you don't understand that, this particular ratio of epinephrine could kill a patient if you inject it, that's on you, okay? So pharm is going to come later, but just understand that it is super important for you to take that seriously, okay? So I included this little poster. I had actually made this poster many years ago for one of my other classes, and I will include it. I'll probably try to just upload it as a document. It's a Word document, and I would pass this out to my students because this particular emergency situation that happens in anesthesia is called malignant hyperthermia. Hyper, not hypo, okay? This is essentially what this is a genetic predisposition of a patient to react to certain general anesthetic drugs, okay? Not everybody will develop malignant hyperthermia under general anesthesia. It's pretty rare, to be honest with you, but if you look here at what it is, it's a lethal genetic syndrome associated with the administration of certain anesthetics. Mortality rate is 5 to 10%. Really might even be higher than that if you don't treat it quickly. This once it happens, once it starts, progresses very rapidly, and if you don't catch it soon, the mortality rate jumps up very high. Okay, so what you're going to end up seeing early, and this could happen just within minutes of being given some of these triggering agents, you're going to see an increase where it says ETCO2. That stands for end tidal CO2. So that means the body is exhaling quickly, trying to get carbon dioxide out. Because what's happening on a cellular level is the muscle actually will start to break down. Your muscles will start to break down and release carbon dioxide as like a byproduct, and it gets built up in the blood. So if you start to build up this carbon dioxide in the blood, it also causes the blood pH level to lower, becomes very acidic. The blood will become acidic. So as a response to that, your body is automatically going to breathe it off faster, try to get rid of it, okay? So you'll see that CO2 level rise. There is a little monitor on an ET tube that goes to a little box that anesthesia monitors, and it will start to beep, okay? So there are very different early and late signs of MH. Some of these happen very quickly. Some of these might take 15 minutes-ish or so. Trunk or muscle rigidity, especially in the masseter, the jaw here. Tachycardia and tachypnea. So like I said before, the body's going to try to breathe the CO2 off very quickly. That's tachypnea, rapid breathing and rapid heart rate. Your body's trying to compensate for that. Respiratory and metabolic acidosis. So again, if you have that buildup of carbon dioxide, it causes the blood to become acidic, which can lead to a lot of other issues. Now, what's crazy about this particular thing is why it's called hyperthermia, is the body temperature can increase to, anywhere upwards of 105, 106, maybe even 107 degrees, which is crazy, okay? That's super high. But it's not always an early sign. It might be a late sign or a mid sign, okay? Myoglobinuria, so you're going to start to see a myoglobin from the muscle in the urine, which should not be there. It's usually too big. So you'll end up with kidney issues as well. Late signs, mottled cyanosis, where you're going to start to look like patchy blue. DIC stands for disseminated intravascular coagulation, where essentially your body is going to use up all of its clotting factors and cause like blood clots. But then, because there are no blood clotting factors, will eventually cause you to bleed to death. Crazy. It could lead to cardiac arrest, hypo or hyperkalemia, which is potassium. Okay, so the triggering agents here are not very many, actually. So patients who are under typically like a MAC or a local are not at risk, but these are for general anesthesia. So this one is succinylcholine, or anectine is the other name for it. So we sometimes refer to it as SUX, okay, if you hear anesthesia. So succinylcholine, and then your A&E drugs. So those are the volatile inhalation anesthetic drugs that they're going to be giving. So for example, I know you probably haven't had pharm yet, but Suprain, isoflurane, desflurane, they all end in the A&E drug. They're anesthetic agents that they're going to breathe in that are very volatile, very potent, that can trigger this particular response. Now, if they're breathing in something like nitrous oxide, it does not trigger it, okay? Just these, and SUX is injected. So if they suspect that this patient does have this, that's why we always ask patients for their medical history. Has anyone in your family ever had a reaction to anesthesia? If they have, they might be more at risk, okay? Sometimes patients don't know that they might have this particular genetic predisposition until it happens. It's kind of a bummer. So treatment phase. First of all, you're going to need multiple hands on deck. This is not just an anesthesia incident that they handle on their own. Multiple people have to jump in and help. The next thing they need to get is dantrolene. That is the drug that they're going to use to treat this particular instance. Also, anesthesia will discontinue whatever it is that they've been using, whether it was SUX or the AIM drugs. They're going to hyperventilate with 100% oxygen. We're trying to counterbalance this excess carbon dioxide. If the procedure hasn't even started, if they haven't even made an incision, they will not continue. If they have made an incision, we're going to wrap it up as quickly as possible, close them back up, because they're going to need treatment for a long time. Dantrolene, again, is the drug of choice. The brand name for dantrolene is Dantrium, okay? There are a couple others now on the market. I think one of them is called Ryanodex, so that's also an option. A lot of certification exams will ask you what the proper dose is for dantrolene because you as a surg tech are capable of reconstituting it. This drug needs to be reconstituted. So it comes in a vial of it's in powder form, but it has to be reconstituted with like normal saline mixed together. And so it's 2.5 milligrams per kilogram. That's the dose. So, if your patient weighs 100 kilograms, you're going to need, what is that, like 250 milligrams? But the thing is, a lot of, at least around here, since this is so rare, we don't keep a lot of dantrolene around, okay, which is crazy. We actually will have to go get dantrolene from either another unit like PACU or even another facility down the road. We have like an agreement that we could borrow theirs if need be because it's so rare, it expires quickly, and it's very expensive. So you have to have a lot of dantrolene. You also will be giving them dantrolene like for days because they could revert back to, these signs of MH. So it takes a long time to treat and fully get that out of their system. Okay. Something else you could help with as a surg tech is cooling the patient. So we will put ice packs all around the patient, especially in like, the tops of their head, their neck, like the pressure points where the blood is close to the skin. If they're open, we can get that slush machine and put sterile slush inside the body, pack any body cavity with ice, essentially, because we do not want that patient to go upwards of like 105 degrees because that's going to lead to other issues. So it's all hands on deck, a lot of teamwork. We in our facilities have a malignant hyperthermia crash cart. It is a cart dedicated to this particular instance, and a lot of facilities require that. Okay, so I just wanted you to be aware of this particular very serious, even though rare, very serious anesthesia side effect that could affect you. It's actually not even a side effect. Side effect's pretty common. It's considered an idiosyncratic effect because it's so rare. So I just wanted to dedicate this this lesson to my good friend Amy West, who just passed away recently. She passed away on Thursday. I'm going to try to get through this without crying, but she committed suicide, and she was a very dedicated healthcare professional. She was the person who got me into this field. She inspired me to become a teacher. I worked alongside with her. For this is my 10th year of teaching, and I've worked with her for almost all of them up until recently. So she was an excellent surg tech, excellent mentor. She affected the lives of thousands of people. Okay. So whenever someone tells you you're just a tech, you're just a surg tech, you can't progress or do anything in that field. That is such a lie because she's proven that she's not just a tech. She has inspired many people. She has helped many thousands of people, students, obviously patients. You don't understand the reach that somebody has, I think, sometimes until they're gone. The outpouring of love that she's had over the last several days have been outstanding. And all I can do is hope that I can carry on her legacy and do what I possibly can to also positively affect other people. So be sure, and I just want to challenge you to make sure you understand that you have, as a surg tech, even just as a human, the opportunity to impact people. You have the opportunity to impact and not just consider surg tech, in the opportunity for advancement. It's much more than just a job. If you are getting into this just for a job, you have to realize it's much bigger than that. Surgery is a different world. I cannot stress that enough. You become family with the people you work with. And when they're hurting, you're hurting. You're there for each other when patients die, like I said. You're there for each other when one of your teammates dies. It is super hard, but I'm doing my best to look at the positive and trying to impact for good in her honor because I know that's what she would have wanted. So be conscious of that, be aware of the importance of mental health and taking care of yourself and stepping back if it's too much. I cannot stress that enough. So I just wanted to dedicate this to her. I'd be remiss if I didn't, because without her, I wouldn't be where I am. So just wanted to put that out there. And again, if you have any questions, please feel free to reach out to me. I do have office hours today. I apologize if I haven't gotten to you, over the weekend. It was a very rough weekend. So I do apologize for that, but reach out with any comments, questions, concerns you may have. Great. Have a good day.